Hi, this is Brian Kim. I'm going to share with you case number 240 in the Best Way to Do Cataract Surgery series. And the purpose of this title is not to suggest this is the best way, but to get you to think about your best way and how you do surgery, which means thinking critically of your technique and thinking about how you can refine and hone your technique so that you can provide the very best for your patient. So this is a patient with a hypermature cataract. I'm going to use trypan blue. And as I'm trying to sculpt the lens is so dense and the zonules are so lax that I'm needing to do something else in order to get more effective sculpting. And so you're going to see how I handle that in this case. Go ahead and place the corneal mark, which will help me to center and size the Rhexus. I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and this is intracameral air, and I want to decompress the anterior chamber. As I push more air in, this will allow me to get a bigger air fill. And this is trypan blue, painting the anterior capsule surface with the dye, and I'm going around with the cannula acting like a paint roller and trying to diffuse that ink all over the anterior capsule surface. Since the air bubble came out so much, I went ahead and put some more air in and then put the remainder of the dye in. Injecting some dispersive viscoelastic to coat the corneal endothelium and push out the dye and the bubble. And then using the cannula to control the eye, I make my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then when I'm ready, I enter. Turning the eye down with the Orlock technique. And then I'm puncturing with the microforceps for the capsular Rhexus. And again, with these dense lenses, I'm acutely aware that there's probably some zonulopathy. So you want to make sure that the Rhexus is not too big. And because of the angle that I have here, you can see I'm using that cannula and twisting it the other way, different from what I normally do. But the result is the same. I'm able to turn the eye to make it easier to do the capsular Rhexus. Coating the cornea with dispersive viscoelastic. And this is the Capsule fornix hydrodissection technique. I place the cannula under the Rhexus edge contra-incisionally. And of course, with these dense lenses, they tend to be disassociated from the bag anyway, and the lens begins to spin. Adjusting my sleeve, I go in with irrigation off, activate irrigation. You can see there's significant reverse pupillary block, which again suggests that there's going to be some zonular laxity. And this is the regular setting. I'm having some trouble with cutting through the lens. You can see there's quite a bit of wobbling. And so what I'm going to do, I'm going to place the chopper contra-incisionally, providing some counterforce. And as I do this, I'm having more effective sculpting through the densest part of the lens. Once I feel like I'm deep enough, I perform the terminal chop maneuver. Since the chopper is out around the terminal side, the equatorial side, I'm able to place the phaco tip deep within the trough, and then I'm able to fracture from that terminal side and propagate that tear all the way across. You can see I'm getting hung up a little bit on some thick posterior lamellar fibers. I turned the lens 180 degrees and I was able to cut the rest of that lens off. Doing a little bit more sculpting here because the lens is so dense. And then placing the chopper around the lens, performing another terminal chop or cross chop modification, kind of a hybrid. I was able to fracture that piece completely in half. That was that first heminucleus. And then turning the lens and sculpting that second heminucleus. And then performing another cross chop. You can see with that one I didn't sculpt as much, and so you can see there's some posterior lamellar fibers, some stubborn fibers there. I'm very carefully trying to get underneath the lens with the chopper. I'm trying to separate, but you can see those stubborn fibers. And then I place the chopper underneath that adhesion, and then I'm able to amputate it. So placing that chopper underneath that adhesion, that leathery adhesion, and then amputating it was the way I was able to separate that adhesion. Placing the chopper around the lens and then crushing the lens between the instruments, and then emulsifying the lens pieces. Again, utilizing mechanical fracturing forces to crush the lens with the instruments. Again, this is a very dense lens, but you can see how very well controlled it is. And by crushing the lens first, I'm able to reduce CDE and vacuum, reduce the risk for corneal wound burn. And because it's very controlled within the central safe zone, and because I was able to make sure that there's no posterior plate phenomenon with the sculpting as well as placing the chopper around the lens, I was able to more efficiently and effectively disassemble the lens into smaller pieces. You can see there's some dense pieces that still don't want to separate. And so once I crack the lens, I basically place the chopper underneath the adhesion, turn the chopper sideways, and then I basically mash the instruments together over the adhesion, and I'm able to break the adhesion. So you're going to see that maneuver over and over again throughout the case. Anytime I have some posterior adhesions, I'm able to slide the chopper underneath the adhesion, turning the chopper sideways, and then I'm able to basically push the phaco tip into the chopper, but because the adhesion is between the two instruments, I'm able to lice that adhesion. So same right here, as I said, I slid the chopper underneath that adhesion, holding the chopper sideways so it's not posterior, it's really more kind of parallel to iris plane. I'm able to push the phaco tip into the chopper and thereby crushing that adhesion, that lens material. And then once I have amputated that piece, I'm able to just continue to crush the lens into smaller pieces and emulsify the lens piece. All right, so that's the first heminucleus. I'm turning the second heminucleus in front of me. But before doing that, I go ahead and push some more dispersive viscoelastic, turn the water off, and then coat the corneal endothelium with more dispersive viscoelastic. You can see how much deepening there is, again, because of the reverse pupillary block phenomenon. Making sure the third and fourth quadrants are separated, placing the chopper around the third quadrant, hooking the peripheral lens, and then crushing it against the phaco tip with another cross chop maneuver, grabbing that fragment with some vacuum, hooking the peripheral lens with the chopper, getting the instruments around the lens piece, crushing it into smaller and smaller pieces, and then emulsifying the lens pieces. Positioning the last quadrant in such a way that I can get the chopper around it, hooking the peripheral lens, crushing the lens with the instruments, making sure I break all of those adhesions, grasping the lens with a little bit of vacuum to hold it, and then hooking it with the chopper from the other side, and then just crushing the lens into smaller pieces, and then emulsifying the lens piece. Again, this is a very well-controlled way to disassemble the lens in this dense lens without having to lollipop the lens, and essentially using crushing forces to disassemble the lens rather than using ultrasonic energy or high vacuum. And this is the last fragment, so you want to be really careful. You don't want that posterior capsule to come forward. You don't really have much epinucleus. You don't really have much cortex. You really don't have much protection. So utilizing crushing forces is really advantageous versus trying to go after these pieces with high vacuum and ultrasonic energy. If you do that, you can have some sudden trampolining, some surge if you're not doing it properly, and then you can rupture the posterior capsule. So of course you can see that that did not happen in this case. So go ahead and take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. Again, you can see there's not much cortex, but I go ahead and just gently try to peel off whatever remnants that are there. Switching to polish mode, polishing under the Rhexus edge, removing lens epithelial cells and looking for any more cortical remnants. Pulsing BSS into the subincisional capsule fornix. And as I do this, you can see there's quite a bit of material that's being liberated. This is why I like pulsing with the BSS, but it does take some care and proper technique in order to make sure you don't cause any trouble with that maneuver. Filling the capsular bag with cohesive viscoelastic and then using the sweeper to polish under the Rhexus edge on the left side and then the right side. The sweeper is really nice because you can access and clean the lens epithelial cells on the anterior capsule and into the capsular fornix in the subincisional area. This is a single piece acrylic lens. I'm going to go ahead and inject it into the capsular bag. Go in with irrigation off, activate irrigation, making sure the haptics are off the optic, getting underneath the optic, tilting it and rotating it 90 degrees clockwise, getting underneath the lens, removing all the viscoelastic from within the bag, polishing under the Rhexus edge, and then removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a hypermature cataract. You saw I used trypan blue to paint the anterior capsule surface, which I think is really helpful with these cases. And the Rhexus went uneventfully. You saw there was a tremendous amount of reverse pupillary block, which tells you there's some zonular laxity as well. As I started to sculpt, I had some difficulty. The lens was rather dense. Rather than pushing too hard on the lens and stretching and stressing the zonules, I placed the chopper around the lens, hooking and supporting the lens from the other side and providing some counterforce as I sculpted. And as I did that, I was able to achieve much more effective sculpting. And then I performed terminal chop, placing the chopper. Again, it was already out to the equator. I just placed the phaco tip deep, crushing the terminal side and then cracking and then propagating that tear all the way across. I did turn the lens 180 degrees just to help separate that last piece, and then went ahead and sculpted each heminucleus and then performing another terminal chop on either piece. By doing it this way, I was able to more effectively separate the lens pieces and avoid the posterior plate. You did see some fragments did have some posterior adhesions, and the way I handled that is basically placing the chopper and sliding it underneath the adhesion, but turning the chopper sideways so it's more kind of parallel to iris plane, parallel to the posterior capsule. So by sliding it sideways, I'm not going to accidentally puncture anything. Sliding it underneath that adhesion and then crushing the adhesion with the instruments and basically amputating the adhesion. And performing this over and over and over again maximizing mechanical fracturing forces by crushing the lens into smaller pieces, thereby utilizing less ultrasonic energy and vacuum, and hopefully providing clear corneas post-op day 1, which this patient had. And this patient did very well, and very happy in this very dense hypermature cataract that wouldn't sculpt. So I hope this was helpful to you, and I thank you for your attention.